Hi, everyone. I'm Dr. Alyssa Watson, and this is Clinician's Brief, the podcast, where we explore the conversations behind the content. We all know that careful, responsible use of antimicrobials is essential if we are going to preserve their effectiveness for the future. As healthcare providers, we play a key role in antimicrobial stewardship. Sometimes, however, that's easier said than done, especially if I have a client standing in front of me that just wants something for their sick pet. And so today I am really excited to be joined by Dr. Jennifer Granick. She's an associate professor at the University of Minnesota, and she's here to discuss 5 common scenarios where you might be tempted to reach for antibiotics, but you probably shouldn't. I know looking at this list, there are a couple on here that I am totally guilty of, and I am looking forward to some pointers in this conversation to maybe strengthen my resolve so I know that I can do a little bit better for my patients when they come in. So thank you so much for joining us, Doc. How are you doing today?
I'm great. I'm just thankful that I've been invited to have this conversation with you.
Good, good. We will jump in here in just a second, but before we do that, if you wouldn't mind just giving a quick bio, introduce yourself, let everybody know how you got to the University of Minnesota.
Oh, well, the University of Minnesota, I think, has a magnet. Um, I did my veterinary school at University of Wisconsin-Madison and an internship at the University of Minnesota. Then I practiced for a year in a primary care practice in Wisconsin and came right back to Minnesota for a residency. Headed out to California for a PhD and then came back to Minnesota. So I'm now a faculty of small animal internal medicine at the University of Minnesota.
Oh, wow.
Yeah.
Wow. You, Minnesota did not have that magnet for me. However, I'm fairly certain in this conversation, a little bit of my Minnesota accent might pop back in because actually I'm from Iowa, went to vet school at Iowa State, but I did my undergrad in Minnesota in Northfield, Minnesota, actually. So I do know the area a little bit. Let's go ahead and talk about some of these cases where we might want to step away, put down the amoxiclav, and just back away from the pill counter for a second. And the first one that we're going to talk about is cats with respiratory signs. So when we have cats with respiratory signs, but no real systemic illness, no fever, things like that, why are antibiotics generally not going to be an effective choice for these cases?
Yeah, that's a great question. And it's really the same as, when we get a cold. Most of these situations in cats are caused by viral infections. And so, the classic is the cat that gets stressed. Probably saw a lot of that recently after Thanksgiving and are gearing up for it again. Um, but, they get herpes flares and they get snotty because of that. And, there's certainly the inclination to want to do something for them, and antibiotics is often what we reach for. But in the cases of viral infections, it's not going to actually help.
Yeah. And can you kind of explain why sometimes antibiotics might actually worsen some of their symptoms, like, for instance, inappetence in these patients?
Yeah, so amoxiclav you mentioned is one of the drugs that we reach for a lot, and it actually has a pretty good chance of causing gastrointestinal distress, and can put cats even further off food. And so we might be, doing more harm, even though we're intending to do good when we're reaching for an antibiotic in that situation. And then, I'm sure everyone listening maybe has tried to pill a cat before, but giving medications to cats, even if we have liquid formulations, can be stressful not only for the cat but for the pet owner, and that stress can kind of increase the stress that might have caused a herpes flare, for example, in the first place, and further delay resolution of that upper respiratory infection. So yeah, we think we're doing good, but sometimes we're doing more harm. And, there probably, kind of less tangible things. Antibiotics affect the gastrointestinal microbiome, and we know the microbiome, as we learn more about it, has all these other beneficial effects, including on the immune system. So there's the potential that there would be an impact there, not proven in cats, but it's one of the things that are frequently on my mind when I'm feeling pressured by an owner to grab an antibiotic.
Yeah. And when I was preparing for this episode too, I was really kind of focused on oral antibiotics, like you were just talking about. But I'm really interested to know your opinion on topical antibiotics in these cases, because we definitely have several different topical, ophthalmic preparations. And I have even seen some clinicians use some of those preparations, those ophthalmic, drops that contain maybe an antibiotic as well as a anti-inflammatory, like a corticosteroid, in the nose in some of these cats that are snuffling. And so I wondered kind of what you felt about that.
Yeah, that's a good question. I can say there's not real good evidence for utilization of those topicals in the nose. I mean, certainly if applying them to the eyes, that's going to be based upon what you're seeing clinically. If you got a cat with corneal ulcers or a really red eye, then they probably need some some attention, some topical therapy. But um, in terms of the adding those to the nose, there's a few reasons that I would probably recommend against it. So, one is that, again, cats typically are affected by viral upper respiratory infections. And so, utilizing topical antimicrobial in the nose is, again, probably not going to be very useful. Um, Again, it's likely to add stress. I think getting drops in the nose might be even more difficult than down the gullet. um, and then lastly, if there's a good amount of nasal discharge, then you're probably not getting those drops to where you really want to treat them, which would be the mucosal surface. It's a bit tricky because if you're thinking about using drops with steroids, for example,
Mhm.
potentially steroids would decrease some inflammation. What it might also do is just allow the virus to replicate more. So I don't really have a good answer for that, but I think drops in the nose, while they seem like a good idea, probably not going to be as effective as you think they are. And if they're doing something, they may just be loosening up some of those thick secretions and allowing the cat to snot them out.
Mhm. Mhm. Yeah, it's another thing that I have seen recommended, or I've actually even recommended myself, and that's just those saline, over the counter saline drops to loosen up that mucoid discharge and get them to sneeze it out.
Yeah, yeah. I think humidification and in any way that you can get that to happen is great. I do sometimes recommend saline drops, but I
Mhm.
think owners usually can get that in for like a day, and then the cats will have none of it. So
So, humidification, you said. What other non-pharmacological treatments are we able, like I said, oftentimes we just have a client standing in front of us that just wants to do something. And so, what things can our client do? And really, how long should these symptoms typically last, in these it's URI cases before we are concerned that we might need something stronger or actually need an antibiotic?
yeah, so great questions. I'll answer the last one first. So, most cats are going to resolve these URIs on their own in about 10 days, to 2 weeks. So they should start, you should start seeing improvement, by the end of that first week of clinical signs. If they're going beyond 10 days, that might be a reason to intervene with antimicrobial treatment, because in that time frame, they might have a secondary bacterial infection that you do need to treat, or depending on what you're seeing clinically, they may be cats that need like an antiviral therapy like famciclovir. But most cats are going to resolve on their own within that 10-day period. What can you do at home? You said that owners want to do something, and I think that's a really really important point to make. When we're not going to prescribe an antibiotic, which some owners have come to expect, what we really need to do is make sure that pet owners know that we want their cat to feel better just as much as they do, and give them those positive actions that they can do that are going to be things that provide relief for their cat. And so I mentioned humidification. So just putting like humidifiers in the house. I think the other really common recommendation is to put the cat in the bathroom when you're taking a shower.
Mhm.
I think that really helps. And, like, it makes sense, right? Because it helps when we have colds.
Mhm.
We like to take a shower, and that again is something that breaks up those really thick nasal secretions and decreases kind of the pressure in their sinuses. Cats have a really strong connection with smell in terms terms of their appetite too. So anything we can do to make their food a little more stinky. So that might be, switching to a wet food if your cat accepts it. I have one cat that is not interested in wet food, but wet food and warming it up can be helpful. Adding some tuna juice. You don't want to feed only tuna, but adding something kind of stinky as a topper can be helpful too. And then if that's not working, then appetite stimulants are a really good idea in these cases, just to make sure the cats continue to eat, because that's obviously part of their recovery as well. And
Certainly.
then the other thing I recommend to owners, which may or may not resolve things quicker in the moment during an outbreak, but might help prevent further flares of herpes virus, would be all of the things that we already know how to do when we're dealing with cats with feline idiopathic cystitis. So putting the pheromone infusers around the house, giving them vertical surfaces and places to hide, that type of thing.
Yeah. So leaning really back into all of those things that help decrease stress in the cat's environment. Yeah,
Yeah.
that makes sense. Finally, before we move on from feline URIs, what's your opinion on vaccinating kittens for FVRCP if they're showing mild symptoms? I have this all the time where a kitten comes in, for its booster, its second or third FVRCP, but it has a little, maybe watery eyes or a little clear discharge from the nose. How do you feel about that?
So I am a internist, so I'm just going to preface with that. I'm not often the one doing the vaccinations, but I hear you. And I would say, uh, you know, yes, we all got taught that as a rule of thumb, if you have a sick animal, you want to avoid vaccinating it, right? We want their immune system to not be preoccupied when we're trying to ask it to do something like develop immunity to a vaccine. But if they're only showing mild clinical signs of disease, I think it's just fine. Um, in the case of kittens, I don't know that there's a ton of data, but there is one study that, well, it's a little bit older, but it was out of Colorado, and they looked at cats with chronic upper respiratory infections, and giving those cats intranasal vaccination actually was helpful in resolving clinical signs. So, there might be a reason to vaccinate these cats. I mean, obviously, you don't want to substitute intranasal for the full FVRCP, but I would say if the cats are showing mild clinical signs, I think you're weighing risks, and I think the bigger risk is not protecting them with the vaccine.
Sure, sure. Let's move on to canine illness, okay? Now, we've definitely seen a shift in terminology during my career. I've been practicing for about 20 years, and we're no longer really using the term kennel cough. Now it's this canine infectious respiratory disease complex, or CIRDC, which is not as easy to say, I will tell you. But what types of pathogens are we looking at when we're looking at acute canine respiratory illness? And also, what kind of diagnostic testing should we be doing in these uncomplicated cases? Do we need to be taking chest x-rays or running, there's some really great PCR panels. Do we really need to be identifying these pathogens if we have an animal that's not too sick?
Yeah. So, yeah, good question. The When dogs are presenting with CIRDC, which I often still use the term kennel cough if I'm talking to owners because they know that, and it's just not quite as much of a mouthful. But it's often a combination of pathogens. There are definitely viral players, parainfluenza, adenovirus 2, can be even like distemper virus, canine influenza, especially depending on where you are geographically. There's respiratory coronaviruses, and then there are the pathogenic bacterial um, organisms, Bordetella, Bronchoseptica, Mycoplasma species, and then the really bad one would be Strep equi, Zooepidemicus, and that can cause really severe disease, and that happens really quickly. So I don't know that there's often like a lot of diagnostic uncertainty. You have like a really sick animal in front of you. Um, if you have, the typical uncomplicated case, I don't think you really need to do a whole lot of testing. Your physical exam should tell you whether or not the dog is systemically ill. But if it's like the coughing dog wagging its tail, still willing to eat, non-febrile, then, doing a PCR panel might be informative, but not really in that moment, right? And the thing to remember about those panels is that they can have organisms that are like present in healthy animals. So I don't know that they're super useful for guiding treatment in the individual animal. But if you are in a situation where you're seeing a lot of these patients come in, doing PCR panels in those cases would be helpful because then you really know what you're dealing with. And I think that can be helpful in terms of helping prevent further animals from getting disease. So, and again, chest films in terms of like a typical diagnostic workup, again, in that healthy wagging tail animal that's non-febrile and happy to eat and just has a cough is probably not necessary. I think, using your stethoscope is probably a good enough diagnostic test.
Okay.
And, the key is just, making sure the owners know what to monitor for. They can
Mhm.
always come back in and you can take that chest film later.
Yep. Yep. I do want to talk a little bit though about cough suppressants because
Mhm.
that's one of the places where I start to get uncomfortable about prescribing if I haven't done some of those diagnostics like a chest X-ray. Yeah, for some reason, it was really drilled into me to like that if you suppress the cough, you're suppressing this normal body action of clearing mucus from our airways, clearing debris, and then we could potentially trap that down in the lungs and predispose or worsen our disease. And so just I would love your opinion on that too.
Yeah, so, this is where, is the gray area of veterinary medicine that we all love and students absolutely hate. And I think it really depends on the patient that you have in front of you. So you're absolutely right. That's what I learned too. Cough is a helpful reflex. It gets all that
Hmm.
crud out, and we definitely want crud to come out. So I wouldn't use a cough suppressant in a animal that has a productive cough, right? Because we want that stuff to come up and out. But in the case where it's just a dry cough, there's no productive cough, and the dog's just coughing a lot, using a really short course of a cough suppressant can be helpful because when the dog coughs, it creates tracheal irritation, which leads to a cough, which leads to tracheal irritation. And so sometimes just like a couple days, maybe 3 of a cough suppressant can break that cycle and provide some relief for the pet. If you're, everybody has like a different amount of, risk aversion. Another alternative to help decrease that inflammatory cough cycle would be, potentially use an NSAID as long as the patient's like well hydrated. Um, so maybe Dr. Watson, you want to use an NSAID. Maybe I would use a cough suppressant for a couple of days.
Let's talk about those cough suppressants.
Yeah.
Also, I sometimes will use Mirapatent because that is reported to have some antitussive properties, and sometimes I'll reach for that one too. But a lot of the really good cough suppressants are controlled substances,
Mhm.
and that can sometimes be a barrier to routine prescribing, especially if a clinician maybe doesn't have a DEA license or something like that. So looking at some of these other non-controlled options like guaifenesin, do you feel that those are effective, or should we really be reaching for something like butorphanol or hydrocodone?
Yeah, so I think what you choose, yeah, there are certainly lots of factors, right? There was a study looking at when veterinarians make any sort of prescribing decision, there are like a million things that are influencing that. So certainly one of those is what's available to you. Um, uh, in terms of the dextromethorphan guaifenesin combination, you could certainly try that. I mean, it's a readily available drug. um, the bioavailability of the dextromethorphan in dogs is not so great, and maybe doesn't last so long, but I think it's worth a try. And again, if the dog is minimally effective, I think it's you can kind of scale up when you need to. So you could try that first, and if it's not working, you could try something else. um, the guaifenesin is more like an expectorant and it breaks up mucus. And again, if the dog's really mucusy, I wouldn't want to suppress the cough anyway.
Mhm.
So
Okay. What about some of the other kind of non-pharmacological things, just like the kitties? You throw these guys in the bathroom too?
Yeah, why not, right? I think that might feel good in a scratchy throat. Making sure they're well hydrated is helpful. I think I mentioned NSAIDs could be helpful in these patients, making sure that that they're eating well, that their appetite's not decreased. It just depends. If you have a Labrador that's coughing, it will still eat. I'm pretty sure. I have two of them, but the mini poodle may not. And so
Mhm.
sometimes, just like with the cats, they might need some other supportive care, appetite stimulants. If they're coughing so much they're getting dehydrated and not eating or drinking well, they might need more supportive care. But that's not really the most common presentation, is just that coughing dog. They can cough for weeks, and may drive the owners crazy. And every time they come back in, it's like, you're wondering, is it time now? do I do I prescribe? But it's the same thing really in dogs and cats, that most of them are going to resolve on their own, even if there's a bacterial component, and if they're getting sicker, in that sort of watchful waiting period of the first week or 10 days, then yeah, then we probably do need to intervene with more supportive care and potentially antimicrobials.
Yeah. Yeah. Preparing clients, I think, for that long period of coughing is something that is difficult.
Yes. Yep.
So,
Yes, they'd come to you and they say, "I'm not sleeping." And I'm like, "Well, I
mhm.
cannot help you with that, but what I can do is try to help your dog."
Yeah.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serolaner Moxidectin and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serolaner belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
Let's go ahead and move on now from respiratory infections and let's look at urinary tract. Another thing that has changed significantly during my time in practice. So much. I really have become a lot more comfortable with this concept of subclinical bacteriuria and not giving antibiotics to anything that we see, bacteria just in the urine. Um, I was a little bit surprised though when I read your article, this piece, because there was specifically talked about like the degree of pyuria and the colony forming unit count when we do a urine culture. And both of those things I had kind of definitely used before in order to judge whether or not I thought a infection was real, and needed treatment. So can you explain how do we currently define subclinical bacteriuria?
Yeah, so subclinical bacteriuria um, is defined as the presence of bacteria in the urine. That's the bacteriuria part. It's fun to say. In the absence of clinical signs. So, clinical signs of lower urinary tract disease are plaqueuria, stranguria, hematuria, dysuria. And so we can have bacteria that's in the urine, and it's not causing any clinical problem for the patient. I would just put the one caveat out there, which is that if you have a patient that's systemically unwell, that's a clinical sign, right? Or if they're unexpectedly azotemic or more azotemic, because animals with kidney infections, pyelonephritis, may not have lower urinary tract signs, even if it's an ascending infection. So that's sort of the one caveat. But yeah, bacteria in the urine doesn't always cause problems.
Mhm.
We used to think that the bladder was a sterile place, right? But now we know that just like in the gut and the skin and even the respiratory tract, in the urine, there's a microbiome there as well. So there is bacteria in the urine normally. It's just not normally the bacteria that we would be able to see on a UA or culture. It's not necessarily culturable bacteria, but even culturable bacteria may be absolutely normal in the bladder.
And how common do we even know how common this subclinical bacteriuria is? Or are there other conditions that it seems to be associated more often with? Like you think of diabetes or, some of those other conditions that also affect urinating and drinking and diluting out the urine, all of those things.
Yeah, so it is relatively common in healthy cats and dogs. So in a couple studies, more than 1 in 10 cats and dogs. So 12% of healthy dogs in one study, 13% of healthy cats have subclinical bacteria. We do see subclinical bacteria in patients that have comorbidities like diabetes, Cushing's, chronic kidney disease, and others. And even in those cases, um, where they have some other, significant disease process, we don't always need to treat those. And that's where, it would be great if we had better guidance. um, but, for me, like if I have a patient with diabetes and it has subclinical bacteria, um, as long as the diabetes is well regulated, I'm not too worried about it and I don't treat it. Another clinical situation where people might be inclined to treat but probably don't need to is like patients that are on immunosuppressive drugs. So even in those cases we often don't need to treat. I have one dog that's currently under my care, who's on mycophenolate for immune mediated polyarthritis, and we just look at his E. coli every time it's in the bladder, and he doesn't care.
Yep. I'm in Nevada, on the West Coast, we see quite a bit of allergies. And so I have a lot of patients on oclacitinib. And I know that for a little while was also something that we were wondering whether or not we needed to treat these animals if they had, bacteriuria when they were on that immunomodulatory drug. So definitely something that I actually see quite frequently. You mentioned E. coli in your patient. Is there a specific bacterium that we see most commonly with subclinical bacteriuria, or can it be any of our common, urinary pathogens?
Yeah, it can really be any of the common urinary pathogens. E. coli is probably going to be the most common just because it's the most common thing that we see in the urine. Enterococcus is one that we see, and it's one that we see pops up. Like if you have a patient that has an actual clinical urinary tract infection that you treat, if you were to look at that urine later, you might see, cocci in there, and a lot of times it's enterococcus and it's just hanging out. So yeah, I guess so it could really be anything, and I would say staff would be, again, throwing out a little caveat. If you see subclinical bacteria, but you're culturing like a staphylococcus in the urine, you might at least want to monitor that patient just because we know that that's a risk factor for struvite stone formation in dogs. Um, so that's one where I might be a little more cautious about how I proceed, but usually we can just leave these alone. And you know um, if we start treating these patients with subclinical bacteriuria with antibiotics, what we might be doing is just inviting a more pathogenic organism to take over. And at the very least, we might be creating some antibiotic resistance. So if the patient does develop a clinical infection later, it might be harder for us to treat.
Be harder to treat. Yeah. And that was a great little pearl about the staff. Thank you.
Yeah.
um, let's move on. Okay, the next one, I think this is probably the one that has been getting a lot of attention lately. There's been a few studies, specifically I know on metronidazole in acute diarrhea cases, and this seems to be one that people feel very, very passionately about. And it's a frequent, presentation, right? Animals come in for acute diarrhea, especially dogs, all the time. How often is non-parasitic infectious colitis, the actual cause of acute diarrhea?
Yeah. So I that's a good question in terms of like all of the diarrhea cases. How common is it? This just non-infectious, non-specific. I don't know if I have a number for you for that, but I would say like most presentations of diarrhea are going to be that acute non-infectious diarrhea. And in some of the studies that we've done here at the University of Minnesota, in different settings like primary care and referral practices, it's about 17% of canines that are coming in for acute diarrhea.
Mhm.
So it is really, really common.
Yeah, and that's another one too that clients really want fixed right away, and you can't blame them, right?
Yeah, they don't want to wake up in the middle of the night and let
Mhm.
their dog out, or, clean the carpet
In the morning.
every
Yep.
day. Yeah.
Exactly.
Yeah.
Exactly. So this is one place, I brought up metronidazole already, but this is a place where, in my career, it was, kind of routine to say, well, we can use metronidazole because, hey, metronidazole also has these other properties, it's antiparasitic and just in case we have Giardia or something like that. But when we do suspect a parasitic infection, it seems like empiric treatment with fenbendazole is starting to be a little bit favored to that. Can you speak to that a little bit?
Yeah. Yeah. I think the reason why metronidazole has historically had all this popularity is because of the association with Clostridium perfringens. There are studies that show when dogs have acute diarrhea, we see more Clostridium perfringens. That's not necessarily mean that it's causative, but I think that's been the target of utilization of that drug. But what we now know is that there's another Clostridium, Clostridium hyrenosis, and that is a beneficial bacteria in the gut. It's a really important one in dogs. It's important for normal gut function. It supports colonic mucosal health and the gut immune system, decreases inflammation, and it does all this. One of its really important functions is metabolizing bile acids to secondary bile acids. And so it can be anti-inflammatory in that way. And so when we're using metronidazole, we are targeting that really good Clostridium, that Clostridium hyrenosis. And that's what causes, one of the things that causes further dysbiosis. And while we think we're helping by prescribing that metronidazole, we actually might be causing more harm because we're eliminating an important population of bacteria in the gut.
Yeah, that is just really interesting because that is another thing that I have heard claimed about metronidazole, that metronidazole actually has anti-inflammatory effects in the GI tract. But what you're saying is we're killing off the bacteria that actually does have anti-inflammatory effects. Also, another
Yep.
thing that has been put out there as a justification, if you will, for prescribing it is kind of preventing this bacterial translocation. If there's ulceration of the GI tract or a little bit of bleeding, sometimes with these acute diarrhea cases, I'll get a little bit of bright blood from straining or things like that. Is there any evidence to support any kind of anti-inflammatory claims of metronidazole itself in the GI tract?
Yeah, so there's no evidence supporting that anti-inflammatory, like magical effects of metronidazole, which is funny because I learned that too. Like way back in the day when I was doing my internal medicine residency, this was the adjunctive therapy for dogs with
Mhm.
IBD because of that magical anti-inflammatory effect. But it actually doesn't exist. There's no evidence for it, and as we mentioned, it can lead to further inflammation of the gut because it's eliminating that Clostridium hyrenosis population. Um, and then in terms of the dogs where there's bloody diarrhea, there was just a paper published very recently looking at dogs with acute hemorrhagic diarrheal syndrome, which I would say like would be the dramatic end, right, of the spectrum of dogs presenting with acute diarrhea, acute bloody diarrhea. And even in those dogs, antibiotics were not more effective than supportive care. So, and there are other studies that suggest that we don't need to intervene with antibiotics in these cases unless there's already signs of sepsis. And then obviously we want to, but then metronidazole wouldn't be the drug of choice. It would be,
Anyway,
more,
yeah.
four quadrant coverage, which is often like a moxiclav and a fluoroquinolone or
Mhm.
aminoglycoside. Um, but unless there's evidence of sepsis or if you have a degenerative left shift, then there's really no benefit of adding the antibiotic. And as we already talked about, there's the potential harms. And, amoxiclav will target that good Clostridium as well. So it's not like substituting one antibiotic for another is the key.
Okay.
So most cases, even of acute hemorrhagic diarrheal syndrome, just need supportive care.
And so I'll put you on the spot here. What
Okay.
is your first line therapy? Like, what do you consider supportive care for acute diarrhea?
Yeah. So food, right? Dietary fiber for those patients with the acute colitis is really magical. And, there are lots of options for diets that are, specifically formulated with fibers that, prebiotic fibers that really support the microbiome. And so, almost everyone has those in their clinic already. So that can be really useful. If there's a small bowel component, then I tend to, instead of a high fiber diet, to do like a highly digestible diet. And there's really good evidence for food being sort of the treatment of choice for these patients. Probiotics, there's less evidence for, and I think that may just be because there's a lot of different probiotics out there. Um, but I will often reach for probiotics too. And depending on sort of the severity of disease, I might reach for a different probiotic, kind of moving from those that have less different bacteria and less total numbers of bacteria to up the scale to those that have lots of different variety and a whole lot of bacteria in a single treatment.
I'll also have owners that have come in and they've tried over the counter remedies, like Imodium and, and some other things too. I've always kind of wondered whether or not it would be okay to prescribe, just a few doses of those.
Yeah, that's a good question. I typically don't do that. I don't imagine it would be harmful unless like you actually do have a pathogenic bacterial infection. You probably don't want it. You want like the salmonella to leave the body if you've got that going on. And just want to make sure that by giving it, you're not causing like cramps and that sort of thing in the dog. Um, but generally, I don't use them. I think dietary fiber often improves the situation rather quickly, and so, usually I think I'm satisfied with the results of that intervention alone.
That usually does the trick.
Yeah.
Okay, the last scenario we're going to talk about is Lyme seropositivity in healthy dogs. And this is one that I don't have a lot of experience with. I've practiced despite being from Iowa and, and going to Iowa State. I have always practiced in Nevada. And down in Vegas, we have this beautiful little bubble where we're kind of in this little valley with no fleas or ticks or anything like that, which is a lovely place to live. But I don't see a lot of Lyme seropositivity. But I do see this question come up all the time in online forums, Facebook groups, things like that. And so that's if we have a patient, we've got, one of these point of care ELISA tests. Oftentimes we're testing for several different things, on one test, but they pop up positive. What do you do next? Should we use these quantitative antibody tests? And do those that we send out to the lab and give us an actual number, do those aid at all in deciding whether or not we need to use antibiotics for these patients?
Yeah, that's a really good question. I agree. It's a really common question that people have. And it may surprise you to know that I would say no. I don't think the quantitative antibody tests are useful in determining whether or not you should treat. There's not a correlation between the likelihood to develop clinical signs of Lyme based upon the titer and or how severe clinical signs will be. And so it's not something that I use to guide therapy. Where I would use the quantitative tests are, if I have a healthy dog that comes in, it's seropositive for Lyme. Actually, the first thing I'm going to do is get a urine and make sure it's not proteinuric. And then I'm going to have a conversation with the pet owner about, preventative care to prevent, the dog from being seropositive for Lyme. But we know when they're positive on these tests, they can be positive for quite some time. And so if you're if you've got the owner on board and they're going to, maybe vaccinate the dog and get on board with monthly flea tick preventative, that's a good investment for them. But it costs money. And what's going to happen is next year they're coming in for their annual exam. They're positive for Lyme again. And they're going to be like, what was all this stuff for? Right. And that's where the quantitative test can be useful, because you can get a baseline quantitative titer. And then as long as the dog didn't get re-exposed, you would expect a year later, even though this, the point of care test is still positive, that quantitative titer should be lower. And that tells you the dog didn't have another, exposure to Lyme where it actually, disseminated and caused an antibody response.
And then you talked about that first thing that you're going to do is grab that urine sample. And I think that this is really the condition that everybody's scared of, right? Of Lyme nephritis. And so how common is Lyme nephritis? And how long after they become infected can Lyme nephritis develop? Can we see it out there 6 months, after a tick bite?
Yeah. So I don't know that there's super robust data, but it's not, I'll tell you that Lyme nephritis is not all that common, right? So if you live in an endemic area, you're going to see it just because lots and lots and lots and lots of dogs are getting exposed to Lyme. I mean, we have some counties in Minnesota where 50% of the dogs are walking around with a positive, Lyme antibody titer. So it's way less than probably 1% of all dogs exposed to Lyme. And even polyarthritis is probably, 5% of dogs that get exposed. So it's not like in humans where you get exposed and you're probably very likely to get ill. And then in terms of like, when can Lyme nephritis appear after infection? I mean, that is the ultimate question, because it's one aspect of Lyme disease that's not able to be recapitulated in an experimental setting. So there's still a lot of unknowns, but if you have a dog that's like recently exposed and it's possible that if you're checking them now and you're checking them 6 months from now, they may not be proteinuric now, but they could be 6 months from now. So some people recommend that on the first time that you have a positive point of care test, you check a urine and make sure they're not proteinuric. And if they're not, some people suggest checking them quarterly for the first year after a new positive test. And I think that's a good recommendation, because you might not catch it right away. The initial damage, it really depends on how significant it is in terms of damaging the glomerulus. And that's going to, relate to how much protein could be in the urine and when it's going to be detectable.
And then if you do have a patient that's proteinuric, so you have your Lyme positive, then you went ahead and got a urine sample, you're proteinuric, do you continue down the proteinuria algorithm looking for causes of proteinuria? Or do we just say, okay, well, we're going to start, doxy or, some reputable treatment for Lyme, since we know we're seropositive and we're proteinuric?
Yeah. So, I mean, that's like, what's the practical scenario and what's like the ideal, like, what would you do if you could do everything scenario? And I would say, let's live in the real world for a moment. If I had a healthy dog with a positive point of care test and it was proteinuric, I mean, I'm getting a UA. So I would first make sure that the sediment is inactive, right? Because if there's like, a lot of bacteria, white cells, and maybe that's what's driving the proteinuria. And if you're uncertain, waiting and rechecking again in a couple of weeks could sometimes help. There are other, causes of protein in the urine. Cushing's disease, we can see protein in the urine. If you have a sick animal that's coming in with, Lyme polyarthritis, they might be febrile, and that can cause some protein in the urine. So you're going to treat that dog with doxycycline anyway, right? So, but if you have the healthy dog that's proteinuric and there's no other obvious cause, I would treat with doxycycline. Okay. You can always send off a UPC to help quantify that protein, which also is a way to help localize that it's glomerular, but I would go ahead and start the doxycycline. What else could you do? I mean, you could refer them, they could get a renal biopsy, and that would confirm that there's glomerular damage, and there's, antigen antibody complexes in the glomerular basement membrane. But if that's not practical or desirable, I would treat with a doxycycline.
Okay. And you kind of already answered my last question about this topic, and that was, when we have these healthy dogs, but they pop positive on a point of care ELISA, this is really time to really kind of sit down and talk more about tick prevention and vaccination, maybe as opposed to antibiotic treatment. Let's kind of wrap up. I was wondering, do you have any specific like phrases or go-to communication tools when you have that client standing in front of you that is expecting, like maybe they've had metronidazole 4 times before, or it's somebody who has these little kittens that get born in their backyard and they've gone for 20 years they've gone into the vet and they've gone home with a little bit of amoxiclav to put in their fridge, and you're the first person that's telling them we're not going to do that.
Yeah, you hate being that person, don't you? Yeah, I think one of the things that makes it easier for me is a lot of these things you can tie into something that they've experienced themselves, right? So like the snotty cat, yes, it's gross to have the cat snotting all over the house because they don't use tissues, right?
Mm-hmm.
But we don't get antibiotics from the doctor for a common cold. And so it's the same thing. Like it's not going to help, and the antibiotics actually might cause GI upset or some other potential side effects. Doxycycline is the recommended drug of choice for feline upper respiratory infections. And, we all know that can cause esophageal strictures. It can cause GI upset. It can cause, liver issues as well. So, there are a lot of reasons not to give it. And taking that sort of watchful waiting approach, I think is useful. And I think using that terminology versus like, I'm not going to give you an antibiotic, but we probably don't need an antibiotic yet. Let's see if things improve. The last time I took my kid to the doctor with an ear infection, they were like, let's see. Most of these guys get better on their own and continue to monitor it. And so I think the good news is that this is common language in healthcare, not just vet med. And so I think people have had experience with it. Um, I think in terms of the diarrhea, uh, we talked about metronidazole causing dysbiosis and can cause, potentially, elimination of populations of bacteria that are helpful. Well, people know all about helpful bacteria. The microbiome's been on the cover of Time, right? And, people understand when they take an antibiotic that they eat yogurt. So, there's that knowledge, I think, that is actually in the culture that, no pun intended, that I think you can tap into to help explain things.
Mm-hmm. Mm-hmm. Yeah, I will have to say I never had so much empathy for our patients as I went to India with Mission Rabies, and I was on Doxy as my malarial prophylaxis, and I like forgot to eat. Like I just forgot that you had to eat before you took it, and I like missed it after breakfast, and like we came back at lunch and we were at the hotel first. I'm like, oh, I'll take that really quick. I thought I was going to die.
Yeah.
It can rip your stomach up. At least it did to mine. So yeah, and I've used that anecdote a couple times with clients, when I'm prescribing Doxy and I'm like, please be sure to feed them. So I think you're absolutely right. Anytime you can tie into something that they're already familiar with, or, give a story that can help, loosen up these conversations and get a little bit more compliance there. So that was the end of all of our clinical questions. And at the end of our episodes, we do play a little game. I hope that you will join us for this. It is just for fun, would you rather questions. Most of our guests do like to play. Would you like to play with us?
Oh yeah, I love games.
Oh, good. All right, here we go. Would you rather discover a new class of antiviral drugs, or would you rather be the first to identify the causative agent of a serious condition?
Oh, that's like an impossible question. I would say I actually would rather discover a new agent for treating viruses just because, boy, we keep seeing new ones all the
Yeah,
time.
we do. And then you'd get to name it after yourself, so which would be really cool too.
I'd probably name it after my dogs.
I'd rather be able to name like a treatment after me than name a disease after me, right?
Yeah, that's true.
Okay. So, next question.
Mhm.
Would you rather have a compliant client that has the most uncooperative pet or a really argumentative client with the sweetheart of a pet?
Oh, option A for sure.
We can always fix that with drugs.
Yeah, right. Gabapentin for the win.
All right. Would you rather complete an international health certificate or would you rather have to do your own taxes?
Ooh, taxes.
Taxes. Oh, those health certificates are so bad. They're so bad. Okay. Would you rather manage a challenging triage situation in a loud, crowded, busy ER, or would you rather solve a diagnostic puzzle in a quiet office?
Oh, option 2. You're talking to an internist here, and that's like what I do every day.
You just go hide in your office and solve these little puzzles.
Oh, just like, yeah, combing over lab work and hundreds of pages of records. Yeah, I love that.
Okay. All right. Final question. This is because it's actually starting to get cool here. I'm sure it's been chilly in Minnesota already, but here in Las
Yeah.
Vegas, just this last week, it started to get a little cool and I needed a coat when I went out in the morning. So if cats and dogs wore leg warmers, would they wear them on all 4 legs or just the back legs?
Oh, all 4.
All right. All 4 legs. They'd look cute that way, wouldn't they?
Yeah, they really would.
That was it. That was all the questions. I told you it wouldn't be too bad.
That was fun.
I just want to say thank you so much for sharing your insights, all of your advice. This has been a really valuable conversation for me, and I'm sure it was for our listeners as well. And to our listeners at home, thank you so much for joining us. We'll catch you later on the next installment of Clinicians Brief the Podcast.
Thanks so much for having me. It was fun.
Thank you for joining us for today's episode of Clinicians Brief the Podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.